after class today, I'm gonna also do another HESI review. I'll probably pick another one of the Kahoots to do for that, but okay. Make sure this week you guys are doing your practice HESIs, both of them. There's 2 separate ones. And then also, oops, goodness, you guys don't want to hear that. Oh gosh. And then also make sure you're doing your week 10 NCLEX questions. Okay.
Miss Becker, I only have my phone, and I don't think it's gonna let me log in Cahoots and my phone. I mean, I don't think it's gonna let me log into Cahoots while playing the game. But
Oh,
my iPad is charging up right now. It's just dead.
okay. Can you join us when your iPad charges up enough to join?
Yes, ma'am. As soon as it turns
Okay.
on, I'll get on it.
Okay. Yeah, because your camera's off. I bet that's why. Since you were trying to get on Cahoots. Jasmine, we're gonna do Kahoot to start with, so if you can join us.
Okay, I'm logging on now.
Okay, thank you. Yeah, so make sure you guys are turning in all of your work for this week.
Sorry, Professor Becker. My internet, they said that they're working in the area, so
Okay.
it keeps coming and going. I'm
That's
trying to
okay.
sign into Zoom on my phone so that I
Okay.
don't keep getting kicked out of the class.
Okay, that's fine. I understand. Okay. So make sure you guys are turning in all of your homework so you're not missing points after I turn on homework grades, okay? And then next week will be your guys' HESIs. Make sure you know what time and what place you're supposed to be where, okay? If your campus has a testing time during actual class time, so 9 to 11 on Mondays, that should be the time you're signing up, okay? But if they don't offer that section or that time, then just make sure you're signing up for where you're supposed to be, okay? Deal? Any questions about that? No? Okay. All righty, we'll go ahead and get started here. And the code Destiny should be at the bottom still when we start with the question, so you should still be able to join us.
Okay.
Okay. A 1-year-old with pneumonia is placed in a mist tent with oxygen. Which nursing intervention has priority? Give small small feedings, chart the breath sounds, keep a bulb syringe at the bedside, encourage siblings to visit. Yep, good. Suction at the bedside, whether it's a bulb suction or wall suction. If you're in a hospital setting and they're on a mist tent, most likely you're going to have wall suction set up. And that would be more beneficial for suctioning kiddos. But at least have some sort of suction readily available. Okay. Good. Charting breath sounds is also important, right? It's a respiratory kiddo, but not necessarily priority. Good. All right, the purpose of knee to chest position in a child with tetralogy of Fallot is to decrease blood flow to the lungs or to increase blood flow to the lungs. Yes, increase blood flow back to the lungs. Yep, good. Okay, you're caring for a child with tetralogy of Fallot who suddenly becomes cyanotic with SATs in the 60s. What is your first action? Administer morphine, administer oxygen at 100%, prepare to administer IV fluids, or place the child in a knee to chest position. What's your first priority? This kiddo. Yep, need a chest position. Good.
Miss Becker, can you put in the number for the cahoots?
Oh, what can cause rheumatic fever? Vomiting, diarrhea, strep throat, or UTI? Yep, strep throat. All right, hang on. I'll put that in there right now, Jasmine. 3, 5, 2. All right, there's the code for Cahoots. And it's just kahoot.it. Is it letting you join, Jasmine?
It's telling me to get ready. I'll be able to join soon.
Okay, perfect. Okay. It's a multi-select. Signs and symptoms of rheumatic fever include what? Heart valve damage, chorea, polyarthritis, subcutaneous nodules over joints. Yep, good. All of those things. Doesn't mean that every kid with rheumatic fever has every single one of those symptoms, but those are all possibilities of symptoms, okay? And chorea, remember what that was? What was that? That was kind of like the abnormal movements, like dance-like movements, shoulder rolls, shoulder shrugs. You'll see some kids do like a neck twitch, but they'll try to make it like a hair, like they're fixing their hair. So like a form of a tic, chorea is. Heart valve damage, that's not always the case, but it can be. Multiple joints with arthritis, so that's your polyarthritis, okay? And then the subcutaneous nodules over the joints, that's going to be the bumps kind of in those joint spaces. Good. Okay, another multi-select. Rheumatic fever and rheumatic carditis diagnostic findings. ESR, EGD or EKG, ECG, CRP, and myoglobin. Which of those are diagnostic findings for rheumatic carditis and rheumatic fever? Yep, everything except for myoglobin. Okay. Good. And ESR is elevated sed rate. Okay. CRP is also an inflammatory kind of marker. And then an EKG, obviously, to look at the heart to see the carditis and if it's affecting the heart rhythm. Okay. BSD creates a left to right shunt leading to excessive pulmonary blood flow and pulmonary pressure, artery pressure, resulting in peripheral edema, pulmonary ischemia, pulmonary edema, or pulmonary hypertension. pulmonary hypertension. Okay, good. So think about that pressure. Remember, if it's shunting from left to right, usually the left side has higher pressure because that side is pumping to the whole body, right? So when it's shunting left to right, then it's going circulating multiple times to the lungs and not necessarily circulating as well out to the periphery. So your pressure, your blood pressure is going to be higher in your pulmonary system, okay? So in your lungs. So that's where you get that pulmonary hypertension. Okay. Hi, Tiffany, you can join us in the Kahoot.it, and then I put the game pin in the chat if you can see that. I'm not sure if you can since you joined us. Are you able to see that, Tiffany?
Yes, I am.
Okay,
my phone is dead. I was out of town this weekend, so I have to
That's
charge it up before I can join.
That's okay. So if you can just join us on Kahoots. Okay, multi-select. Select all that apply. Hypothyroidism, signs and symptoms. Cold intolerance, excuse me. Weight gain, constipation, bradycardia. And it was a multi-select. Yep, good. All of those. Cold intolerance, weight gain, constipation, bradycardia. Those are all signs of hypo, so low thyroid. Okay. So these patients will need to be on a thyroid replacement like levothyroxine. Okay. Or Synthroid is the other name for that. Good. Okay. What is parallel play? Playing with other children, playing alone, playing alongside other children, but not with them, playing checkers with another child. Yes, playing alongside other children, but not playing with them. Good. All right. At which age does a child begin parallel play? 2 to 3, 3 and up, 0 to 2, or less than 3? Two to 3. Yep, good. That one's kind of tricky because 3 and up, could also fall in that category, but the 2 to 3-year-olds are usually the most, 2-year-olds, 3-year-olds, you're going to see parallel play. At 4, most of the time, they're more interactive with each other. Good. Another multi-select. What type of infection is acne? Local, fungal, bacterial, or viral? Local and bacterial. Good. And it's local because it's not all over the body, right? Acne is typically in pretty concentrated places like your face or your back. Okay. And then it's always bacterial. Okay, this medication treats acne and sinus infections. Tobramycin, penicillin, ciprofloxacin, or doxycycline. Yep, doxycycline. So penicillin does not cover staph very well. So it really just covers strep, group B strep. So you want something that covers, because it's a skin infection, right? Is acne. You want something that covers both staph and strep. So that's going to be doxycycline. Okay. Minocycline, doxycycline, clindamycin. Those are all things that would cover for acne. Sorry, I'm messaging back. Okay, next question. Okay, a usual treatment for an infant with hip dysplasia is a body cast, triple diapering, a Pavlik harness, or aggressive physical therapy. Pavlik harness, good. All right, Destiny and Tiffany, I can't really see you guys. Jasmine too. Thanks, Tiffany. I don't know if Jasmine she was on camera, so I don't know if she ran to the bathroom. Hi, Jasmine. All right, multi-select. How would you diagnose hip dysplasia in an infant? Positive Ortolani maneuver, affected leg shorter than the others, asymmetrical folds in buttocks, or foot points inward. And this was a multi-select. Yep, good. So asymmetry in the gluteal folds, positive Ortolani, and the affected leg shorter than the other. Foot pointing inwards, that's not with hip typically. That's usually like a tibial issue. Okay. Good. Okay, which of the following are included in a nursing care for myelomeningocele? Assessing urinary function, use of latex gloves when providing care, place the infant in supine position pre-op, and assess neurological function. Yes, assessing urinary function and assessing neurological function. Why? Do we remember what myelomeningocele is?
It affects the kidneys.
Yeah. What else does it affect?
The
The spinal cord, right?
spinal cord.
Uh-huh. Yeah. So that's why you're going to assess your neurologic function and your urinary function. Because depending on where that myelomeningocele affects, it's going to, or is at on the spine, it's going to affect your bladder and sensations with your bladder because of the nerves within your bladder. Okay. Good. And you do not want to wear latex gloves. Why? Because a lot of those kids have latex allergy. Okay. Good. Okay. Most important principle of nursing care for a child with myelomeningocele. Asepsis, exercise, hygiene, and rest. Which one is most important for nursing care? Asepsis. You need to keep that area clean, okay? As sterile as you can, because that is a sterile area that typically lies within the body cavity, right? And until they have surgery, that's how you have to treat it. Okay. Good. Okay. What priority nursing action must be taken to care for a baby with myelomeningocele? Position the newborn supine, assist with bonding, protect the sac, NG tube placement. Protecting that myelomeningocele. So in this picture, you could see, so myelomeningocele is a very progressive type of spina bifida. So spina bifida, they might just have a little bit of a bulge, a little abnormality, but their spinal column and all of that is still intact. Meningocele is going to be, they're going to have kind of a collection of fluid of the CSF fluid, but not any involvement in the spinal cord within that sac. Okay. And then myelomeningocele is going to be the involvement of the spinal cord plus the meningocele, so that CSF fluid buildup. Okay. Good. Okay. The nurse is teaching epistaxis management to a patient. Which would be appropriate? Tilt your head forward, backward, or tilt your head backward and pinch your nose. Lie down flat, place an piece of ice over the bridge of your nose. Blow your nose gently with your neck flexed. Sit and lean forward, pinch the soft portion of your nose. Yep, lean forward and pinch just kind of below the bridge of your nose.
Was this talking about a nosebleed?
Yep, epistaxis.
Okay.
That's nosebleed. Yep, that's the appropriate medical term for that. And you don't want them to lean back because they're gonna swallow the blood, right? So you want to lean forward, okay? And then pinch the soft portion of their nose. They're gonna have to pinch that for, probably 5 to 10 minutes before letting go the pressure to check to see if it's done bleeding. Okay. Good luck having a kiddo let you do that for 5 to 10 minutes if they're younger, but there's ways that you can distract them, like let them play on a tablet or something. Okay, what medication would you question if a person has epistaxis? Sudafed, Tylenol, aspirin, none of the above. Which would you question? Yep, aspirin. Why would you question that?
Aspirin thins the blood, don't it? And kids are supposed to have aspirin, right?
Right. Exactly. Both of those answers are correct. Good. Why aren't they supposed to have aspirin? Does anyone remember what that syndrome's called that they could get with aspirin?
Rye syndrome.
Yep. Good. Okay. If a baby is diagnosed with epispadias or hypospadias, what would we need to teach the parents? Baby will need a urostomy. Circumcision will be delayed. He can be circumcised in the hospital, and this will not affect the baby at all. Which would you teach these parents? Yep, circumcision will need to be delayed. At what age or before what age do we typically do repairs on these kiddos? Hypospadias, epispadias.
Before potty training, or when they start potty training?
Yeah,
so like 2.
before they start potty training, so at 18 months. Okay. Yep. Good. A lot of times it's done before then, but by 18 months. Good. Oh, here, I gave you guys this answer. 6 to 12 months, 12 to 18 months, 24 to 48, surgery is not needed. Six to 12 months. Okay, so I would argue this one because it could be 6 to 18 months is usually when they do the repair. Okay. So those of you guys that picked 6 to 12 and 12 to 18, those are all correct answers. Okay. Good. Okay, what does folic acid do for sickle cell disease? Folic acid helps to make new bone cells. Folic acid interferes with the RNA and DNA to help make red blood cells. Folic acid increases the occurrence of sickling. Folic acid helps make new red blood cells. Yes, folic acid helps make new red blood cells. So that's a part of the production of more red blood cells. Okay. Good. All right. How does folic acid supplementation aid the child with sickle cell disease? Provides iron from the child's diet, provides neural tube defects in the fetus. It is present in green leafy vegetables. It's essential to red blood cell production and fighting anemia. Okay, it's easy, or it's essential to red blood cell production and fighting anemia in kids with sickle cell. Now, folic acid, you hear that in probably your maternity class with expecting moms needing to take that to prevent neural tube defects, right? That's a part of making sure you're taking your prenatal vitamin. But in a child with sickle cell, that doesn't necessarily apply. Okay. So how it helps with sickle cell is by helping to counteract their anemia that they're going to have. Okay. Good. Okay. When measuring urine output of an infant, 1 gram of a diaper is equal to 1 milliliter, 2 milliliters, 3 milliliters, 4 milliliters. This is way back in like week 2. One mil. Yep. So if it weighs 1 gram, it's 1 mil to chart for your output. Okay. And remember, you have to zero the scale with the dry diaper on it, the same size and the same brand, because they all weigh slightly different. Okay. Good. All right. Multi-select. Signs and symptoms of pyloric stenosis are what? Forceful projectile vomiting, current jelly stool, or weight gain, babies are always hungry, abdominal distension. Forceful projectile vomiting, poor weight gain, and the babies are always acting starved. Okay. Good. Main symptom of hypertrophic pyloric stenosis is upset stomach, projectile vomiting, diarrhea, a palpable mass. What's the main symptom for hypertrophic pyloric stenosis, which is just another formal term for pyloric stenosis? Okay. So don't let that confuse you just because they threw another word in there. Okay. Projectile vomiting. That's still your classic sign for pyloric stenosis. Okay. Good. Okay. Causes of autonomic dysreflexia. Urinary retention, hypotension, dehydration. None of these answers are correct. What are your causes for autonomic dysreflexia? Urinary retention. Yep. Because your autonomic nervous system is dysregulated. Okay. Good. And that goes along with your urinary, like your bladder innervation. Okay. Autonomic dysreflexia presents with headache, hypotension, tachycardia, headache, hypertension, tachycardia, headache, hypertension, bradycardia, headache, hypotension, bradycardia. There's two of the same answer. So it's headache, hypertension, high blood pressure, and bradycardia. Okay. That is the correct answer for autonomic dysreflexia. Good. Okay. Multi-select nursing interventions for autonomic dysreflexia. Bowel and bladder training, dangling feet at the edge of the bed, hydralazine for hypertension, or vasoconstrictors. Okay, bowel and bladder training, because your autonomic, there's dysregulation autonomically, which then is going to affect your bowel and your bladder control. Dangling feet at the edge of the bed because they're hypertensive, and you're also going to have your circulation is going to be affected. Okay. Hydralazine for your hypertension to help counteract your high blood pressure. We would not do vasoconstrictors, right? Because that's just going to worsen the autonomic dysreflexia. Okay. If anything, we'd want a dilator. Okay. Good. Okay, true or false? Lyme disease is caused by an infected deer tick. True or false? True. Yep, good. Deer ticks. Dog ticks don't carry Lyme. Okay. And you can see in this picture the difference. Okay. Now, when they're teeny tiny little nymphs, those are actually, it seems like they should be less likely to carry Lyme, but they're actually almost more likely to carry Lyme when they're teeny tiny. Okay. Good. So deer ticks are with Lyme. Okay. Lyme disease treatment includes, this is a multi-sec, cryotherapy, nystatin, doxycycline, colloidal oatmeal. Never mind, it wasn't a multi-select. Doxycycline, okay? So with Lyme, they have to have 21 days of antibiotics. And typically the most common is doxycycline to use, okay? Good. What is a side effect of Lyme disease treatment? migraines, swelling, soreness of muscles, forgetfulness. Soreness of muscles. Yep, good. Now, if you had Lyme that wasn't treated, you would present with muscle soreness, headaches, like migraine-like headaches, that bullseye rash, right? You would have had a bullseye rash at some point. But not everyone knows, you know, if the tick bit you like behind the ear or on the back of your neck, and you didn't realize that it was there for 2 days, and you get a bullseye rash that's kind of in your hairline. You know, so it's not always the bullseye rash piece of it isn't always what's caught. Sometimes it's more like the joint pain, soreness, stiffness, kind of almost like arthritis kind of symptoms. Okay. Okay, which snack would be best choice for a patient with osteomyelitis? Fruits and veggies, chicken nuggets, French fries, or fruit punch? Yep, fruits and veggies, just like for anybody. Okay, propranolol and the use of hyperthyroidism can decrease thyroid hormone synthesis. True or false? False. Okay. So it does not decrease thyroid hormone synthesis. Okay. Good. All right. What is the primary use of PTU in the management of hyperthyroidism? To replace deficient thyroid hormone, to increase the production of thyroid stimulating hormone, to treat thyroid cancer, or to decrease the production of thyroid hormone? To decrease the production of thyroid hormone, because PTU is utilized in hyperthyroidism because of that effect, because it decreases the production of thyroid hormone.
I take both of the last medications and I got both questions wrong.
Oh,
That's
come
so bad.
on. No, that's okay. They're kind of worded funny. That's why it's tricky. You have to make sure you read the whole question and then read all the answers, just like on your HESI. Okay, symptoms of urinary tract infection in children. Not eating, cloudy, dark, bloody, foul smelling urine, fever, or all of the above. All of the above. Yep. Vomiting.
Quick question. The not
Uh-huh.
eating and drinking gonna come from them not wanting to go to the bathroom, right?
Right. It's because they feel a lot of times when they have a UTI that they could vomit plus the fever.
Okay.
Yep. So it's more related to the nausea and the pain. Good. Okay, the recommended schedule for DTaP is 1 month, 4 months, 8 months, and then 15 to 18 months. 2 months, 4 months, 6 months, 15 to 18, then 4 to 6 years of age. 2 months, 4 months, 6 to 15 months. Birth, 1 to 2 months, 6 to 15 months. Yes. 2 months, 4 months, 6 months, between 15 and 18 months, and then again at ages 4 to 6. Okay. And that's your diphtheria, your tetanus, and your pertussis. And these are extremely necessary, especially right now. Lately, I've been seeing a lot of kids with pertussis, even kids who were vaccinated, like teenage age kids. So making sure that we're keeping these babies vaccinated so pertussis doesn't get out of control is really needed. Okay. 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 A sign you may note when assessing developmental hip dysplasia: 2 skin folds on the back of both thighs, one leg shorter than the other, hypotonic leg muscles, or bulge at the hip area. One leg shorter than the other. Yep, good. All right, and multi-select. Which immunizations are required for school-age children? Varicella, diphtheria, tetanus, pertussis, MMR, measles, mumps, rubella, and polio. Which one for school-age kiddos are required? All of them. Yep. Usually for school age kiddos, since they've already had all of these when they were infants, they're in combination doses. So you're going to get your DTaP and your polio together in one, and your MMR and your varicella in one. Okay. So they'll get 2 pokes, but those are all necessary for school age children. Okay. Pavlik harness must be worn 6 hours a day, 12 hours a day, 23 hours a day, however long the baby can tolerate it. "23 hours a day. They get 1 hour break out of it. Okay. However long the baby could tolerate it, that would be like 5 minutes, because that baby is going to be ticked as soon as they're in the Pavlik harness. Okay. Just because it's not the most comfortable thing. Okay. So 23 out of 24 hours a day that they have to wear that. An infant with hip dysplasia will wear Pavlik harness. What are appropriate nursing interventions? Maintain flex and adducted position of the hips. Take the harness off for bathing. Maintain direct skin contact with the harness. Administer sponge baths. Administer sponge baths. Yep. Because, you're bathing, depending on how you're manipulating the hips while they're bathing and how they're kicking around, that can affect their hip dysplasia, make it worse. So just sponge baths when they're doing their Pavlik harnesses. Okay, multi-select. Caregiver teaching a patient with a Pavlik harness includes refraining from holding, understanding the child will be delayed, checking for skin breakdown, continue to diaper around the harness. Yes, checking for skin breakdown. That's going to be your biggest thing for Pavlik harness. Okay. Good. Okay, nursing interventions and patient teaching for the treatment of head lice and scabies include clothing, linens, and bath articles thoroughly cleaned in hot water, complete isolation from the public, special carbohydrate diet to promote healing, cut and shave off all hair. What's your patient teaching? soon as we start talking about head lice, I don't know about any of you guys, but my head starts itching. So if I start itching my head, I can't help it. Clothing, linens, and bath articles need to be cleaned thoroughly in hot water. Another thing to talk about parents, with parents, is making sure that everyone in the home is treated. Okay. I would just treat everyone all at the same time, even if you haven't seen any critters on the other kiddos, just treat them all. And then also vacuuming. It's forgotten a lot to vacuum carpets with kids with head lice. Okay. So vacuum, thoroughly vacuum. Okay. Which comment by a parent whose child has head lice indicates nursing education was effective? We are using a medicated bath soap to kill lice. I frequently check the scalps of my children for reinfection. I've washed all hats and linens in hot soapy water. We are no longer attending school and I'm homeschooling from now on. I washed all of the hats and linens in soapy water. Yep, good. Okay, multi-select. Which of the following nursing care interventions are appropriate for respiratory distress syndrome in infants? Suction, maintain temperature, provide adequate environmental stimuli, and administer oxygen as needed for saturations less than 90%. Or 90% is what it says. Poor little preemie baby. Yes, so suction, maintaining their temperature, right? And actually environmental stimuli in specifically infants who are having respiratory distress, which typically are like, NICU preterm babies. You actually want like minimal environmental stimulation in preemie babies or babies who are really, really sick. Okay. Until they're like, off the vent and a little bit more stabilized and not in their distress. Okay. And then, of course, administering oxygen as needed if their SATs are below 90. Good. All right. Which of the following is a mainstay of nursing care for bronchiolitis in children? Adrenaline, salbutamol, hypertonic saline, or corticosteroids? Okay, this is something that the books have not caught up to yet. Okay. The books are still saying hypertonic saline nebulizers. That's not something that we do routinely anymore with kids with bronchiolitis. So bronchiolitis, what most commonly causes bronchiolitis? What virus?
Is it RSV?
Yep, RSV. Yep. So with RSV, you suction those babies with saline. Okay. But this is saying hypertonic saline, which is nebulized. Okay. But your treatment for kids with RSV is obviously maintaining their work of breathing and watching their oxygen and all of that. But suction is going to be your best friend in those babies. Okay. But as far as your book's concerned, it's hypertonic saline nebulized. Okay. But just know if you go practice as a pediatric nurse on a floor somewhere, you guys will not be doing that routinely. Okay. All right. Leading cause of childhood poisoning is plant, gasoline, medicine or drugs, flowers. Medications. Yep. Good. Okay, teaching for prevention of UTI includes all of the following except voiding after sex, wiping front to back, wearing cotton underwear, and limiting fluid intake. Which are all of those are a part of teaching except what for preventing a UTI? Limiting fluid intake. Yep. You don't want to limit your fluid intake if you're trying to prevent UTIs. Good. Okay. Multi-selects. Appendicitis signs and symptoms include what? Rebound tenderness, abdominal guarding, bloody diarrhea, pain at McBurney's point. Okay. Rebound tenderness, abdominal guarding, and pain at McBurney's point. Bloody diarrhea does not typically happen, but regular diarrhea can happen in kids with appendicitis. But your classic signs are rebound tenderness, that pain at that McBurney's point, which is in the right lower quadrant, right? And guarding their abdomen. Good. Okay, true or false? Appendicitis signs and symptoms are right lower quadrant pain that improves with hip flexion, nausea, vomiting, and tenderness at McBurney's point. True or false? True. Yep. So your right lower quadrant pain, if you have them flex their hips, it usually improves. Okay. Temporarily. Good. Okay. Which parameter should the nurse consider while assessing a patient with cystic fibrosis? Recurrent lung infections, decreased life expectancy, abundant bronchial mucus, altered pancreatic enzymes production. Yeah, the abundant bronchial mucus. So if they're having abundant bronchial mucus, you have to get concerned about an infection going on, right? If their mucus is worse than typical. Okay. Good. Nurse is assessing a toddler who has cystic fibrosis. Which of the following findings would the nurse expect? Rhinorrhea, visible peristalsis, weight gain, steraturia. Steraturia. Yep. So that's that greasy stool. Okay. That is going to be a common thing with kids with cystic fibrosis. What are the respiratory signs and symptoms, of cystic fibrosis? Respiratory infections, chronic congestion, low tolerance for exercise, sputum production, use of accessory muscles, decreased pulmonary function, forced vital capacity, forced expiratory volume, or all of the above. All of the above. Yep. All of those things are going to be signs and symptoms of cystic fibrosis. Doesn't mean that every patient with cystic fibrosis is going to have all of those things at the same time, but all of those things are very common signs of kids with cystic fibrosis. What are signs and symptoms of esophageal atresia or tracheal esophageal fistula? Excessive drooling, choking and coughing, increased respiratory distress when feeding, or all of these? all of those, okay? So drooling a lot, think about the esophageal atresia or tracheoesophageal fistula. That's when they don't have a full passage all the way right. It's kind of offshooting from their trachea to their esophagus, or they just have esophageal atresia, so it's just not fully, their esophagus isn't fully developed clear to their stomach. So they're going to struggle with eating, they're going to struggle with choking, coughing, and drooling. Good. Which of these are not signs or symptom of tracheal esophageal atresia? Unable to properly feed, frothy saliva, current jelly stools, or abdominal distension. And here's all your variations of atresias and fistulas. Current jelly stools. Why? So if it can't get through to the stomach like it should, then they're not going to be producing stools, right? Not appropriately producing stools. Good. Patients with esophageal atresia and tracheoesophageal fistula may have which of the following symptoms? Coughing, crawling, startling reflex, coughing, choking, cyanosis, fever, shortness of breath, rosy cheeks, coughing, choking, runny nose. Coughing, choking, and cyanosis. Good. Okay. Impetigo teaching should include what? Applying antibiotics over the scabs, removing honey-crusted lesions, and cleaning before applying antibiotics. Apply Santal to remove dead tissue from the wounds. Clean and apply clotrimazole antifungal. Yep. So try to remove those crusts and clean before applying antibiotics. Good. Remember, impetigo, if it says honey crusted lesion, think impetigo. Okay. Teaching to parents of a child with impetigo contagiosa should include cleansing with hydrogen peroxide, give oral antiviral for 3 weeks, apply topical antifungal to the area, remove crust after soaking in Burrows solution, which is 5% aluminum subacetate. Yes, so Burrows solution is what you're going to do to use to get rid of those crusts. Okay. Okay, multi-select. What are low heart rate limits for giving digoxin to an infant and a child? Infant less than 100, child less than 90, infant greater than 120, or child greater than 120. Okay. Yep. So it's going to be less than, right? Because dig is going to slow down their heart rates further to increase their contractility. Okay. So if they're less than 100 and they're an infant, hold the digoxin. And if they're less than 90 and they're a child, also hold the digoxin. Okay. Otherwise, they're going to get too low on you. True or false? Digoxin requires an apical heart rate for 1 minute. Yes. apical heart rate, listening to the chest with your stethoscope for 1 minute prior to giving the digoxin. Some places will also require you to do a blood pressure, depending on the protocol. Okay. When might the infant experience physiological anemia? 1 to 3 months, 0 to 1 month, 2 to 3 months, 3 to 6 months. Two to 3 months. Yep. Good.
I thought they become anemic when you go to switch from breast milk to formula, or switching from milk to whole food, which is like around 6 months.
Well, you don't put, well, yeah, around 6. So it's going to be a time frame. Your most significant physiological change is going to be between 2 and 3 months, but you see them be most frequently anemic about 6 months.
Okay.
Because you're adding foods, but also because that's when mom's like blood and iron and all of that the baby was getting during birth is totally done, is at 6 months. Okay,
Okay.
good. What causes rheumatic fever? Bacteria, overcompensation of the immune system, virus, contaminated food. So, a bacteria does cause rheumatic fever, right? But the cause of rheumatic fever is because the immune system is trying to overcompensate and fight off the strep. And then that's where you get all of the side effects in the rheumatic fever piece. Okay. And it's not any bacteria, it's just group A strep that causes rheumatic fever. Okay. What sign is indicative of respiratory distress in infants? Nasal flaring, intercostal retractions, grunting, or all of the above? All of the above, okay? Intercostal retractions, grunting, nasal flaring, tracheal tugging. So that's where you see their area of their trachea. You're kind of seeing that movement right here, okay? Those are all signs of respiratory distress in infants, okay? They could have one of those things, they could have all of those things, but those are all signs potentially of respiratory distress in infancy. Okay, multi-select. Identify cardinal signs for respiratory distress in infants. Increased heart rate, cold and clammy, nasal flaring, grunting, retracting, apnea. And this was a multi-select. Okay. Apnea, they're no longer in respiratory distress. They're in respiratory failure because they're not breathing, right? Cold and clammy, same thing. So increased heart rate because their heart and their body is trying to compensate for their work of breathing. Nasal flaring, grunting, and retracting. Okay. No apnea, no cold and clammy, because those are very, very late respiratory failure signs. Okay. Good. HPV vaccine schedule. 7 to 8 years, 11 to 12 years, 16 years, 18 years. What's the age range for HPV? 11 to 12 years. Now, in high risk kids, you can give it starting at age 9. Okay. So if they're high risk kids, high risk for early sexual encounters, or, they're immune compromised or something like that, then you might want to think about doing it before 11 to 12 years of age, but typically it's started at 11. Okay. True or false? Symptoms of diabetes mellitus include polyuria, polydipsia, hypoglycemia, weight gain, and fatigue. True or false? False. Which one is incorrect? Why is it false? If they're having polyuria, polydipsia, weight gain, and fatigue, they're probably going to be hyperglycemic, right?
Right.
Yeah, that one was tricky. Tricky. So make sure you read the entire thing and don't let your brain trick you and say, oh yeah, that's right. Okay. So as you guys are doing your HESI test, read the question, read the answers. If something's jumping right out at you, I would read the question again and then read the answers again and see if it's still jumping out at you. Okay. Good. Polydipsia and diabetes is caused by cellular starvation of energy, high osmolarity, fluid loss via the urine, acidosis. High osmolarity. Yep. Good. So they feel that they have to drink and drink and drink and drink. Okay. What causes autism? Pregnancy defect, childhood trauma, brain abnormalities, or no single known cause? No single known cause. Yep. Good. Not exactly sure how all the kids with autism ended up with autism. There's a lot of different factors. Okay, what are the signs and symptoms of autism? Cannot maintain eye contact, hyperactivity, repeats words and phrases, all of the above. Yep, good. All of the above is correct. Autism affects which area or areas? Communication, social pattern, behavioral pattern, or all of the above? All of the above. Yep, good. The most common leukemia in children is ALL, AML, CLL, or CML. Which one's the most common? ALL is the most common. So acute lymphoblastic leukemia is your most common form of childhood leukemia. Okay. Good. Okay, all of these signs and symptoms are seen in a patient with acute myeloid leukemia, except fever, infection, petechiae, polyuria. And this is AML. So it's acute myeloid leukemia. Polyuria. Oh, excuse me. Even if it was ALL that they were looking at, acute lymphoblastic leukemia, polyuria would still be not included in that. Okay. So your concerns with kids with leukemia of any sort is fever, infection, petechiae. Those are going to be your signs and your concerns. Which of these signs and symptoms are most common in the initial phase of leukemia in a child? Sore throat, hyperactivity, high fever, low-grade fevers. Low-grade fevers and kind of on and off. Okay. Multi-select. Nursing care for a child after a tonsillectomy includes frequent pain medication, spicy foods, gum, ice pack to the neck. Frequent pain meds, gum. Why gum? Because a lot of times after a kid has a tonsillectomy, they have pressure in their ears and pain in their ears. So you chew gum and that helps with that pressure feeling. Just like when you go flying, if you chew gum, it helps with the pressure that you might feel in your ears. Okay.
What if they
And
swallow gum?
if they swallow it, I mean, it's not really going to cause any significant issues with the scabs or things like that. Obviously, we tell people not to swallow gum, but it's soft enough that it's not going to like rip off the scabs as they swallow it. Makes
Okay.
sense.
That's
Good
why I didn't choose
question.
it, because I went to thinking they're gonna swallow it.
Yeah, no, good question. Yep. And then the ice to neck area. Okay. Good. No spicy foods. Ouch. That would hurt the scabs. Okay. Child post tonsillectomy is swallowing every 2 minutes. What should the nurse do? Offer warm liquids, inspect the oral pharynx, place an ice collar, or give them pain medicine. Inspect the oral pharynx. What's going on if they're swallowing so frequently?
It could be
What?
bleeding.
Yeah, it could be that they're bleeding after their tonsillectomy. Yep, good. When those scabs could come off and they're bleeding. And kids after tonsillectomies bleed a lot and they can bleed out really quickly. So it's important to make sure that you're watching that as a nurse. Okay. True or false? Sweat tests help diagnose cystic fibrosis. True or false? True. Diagnosed via sweat test. Why? What are they looking for in the sweat test? Or what are they going to find if somebody has cystic fibrosis? Anyone? Chloride, right? Sodium, salt. So if you were to lick someone who has cystic fibrosis, their skin would be really, really, really salty. Okay? Good. All right, during cystic fibrosis sweat test, what two electrolytes are being searched for abnormal transport? Sorry, I kind of gave you guys the answer to this, but now you need to know the chemistry signs of these things. Sodium, Na positive, okay? Na plus is sodium, and chloride is Cl negative, okay? That's kind of tricky. I don't foresee that they would ask you in that way on your HESIs or NCLEX, but it's helpful for you guys to know that as well. So sodium and chloride, that's what they're looking for. Okay, what is the treatment for nephrosis? Hypertensive, steroids, diuretics, naproxen, antibiotics and hypertensive, or Tylenol? Nephrosis. Hypertensive, steroids, and diuretics, because that's the enlargement, right, of the kidneys. Okay. Usually caused from high blood pressure or some sort of blockage, right? So you're going to want to treat their high blood pressure with hypertensive or antihypertensives. Okay. That's what it should say, is antihypertensives, steroids, and diuretics to flush that blockage out potentially. Good. The medication Albacept is used to treat fungal infections. True or false? True. Good. Okay, multi-select. How should a parent check for pinworms? Perform visual inspection of the anus 2 to 3 hours after the child is asleep. Tape test, abdominal palpating, or tape is removed in the morning, placed in a glass jar, and given to a doctor. Okay, perform it. So this was a multi-select. I can't remember if I said that or not. Visual inspection after 2 to 3 hours after that child's asleep. The most common thing to do is do the tape test. So put a loop of like Scotch tape around their perianal area. What happens is those pinworms typically come out at night. So they'll get stuck on that tape. And then when you take the tape off in the morning, put it in a jar or some sort of container so that way the doctor can look at them. Okay. And they'll be able to see them, you know, whether they can see them with the naked eye or under the microscope, but they'll be able to see the pinworms if the child has pinworms. Okay, which of these medications are not used for the treatment of pinworms? Mebendazole, Abraxane, propranolol, Panorate, or albendazole? Yeah, so it's Abraxane, okay? All the others are parasitics, okay? Good. Okay, anabolic steroid side effects include high blood pressure, jaundice, acne, increased risk of cancer, and shrinking of testicles, violent mood swings, increased aggressiveness, or all of the above. All of the above. Yep. And remember, anabolic steroids are not the same thing as corticosteroids. These are the ones that people are taking to enhance their performance, like with sports or things like that. Okay. Good. Okay, last question. Oxygen or mist tents for croup cystic fibrosis treatment have a flow rate of 5 to 10 liters per minute, 15 to 20, 12 to 15, or 1 to 6. (12 to 15). Okay. So those are going to be your high flow rates. Okay. Mist tents are going to be high flow rates. Okay. If you're just doing nasal cannula, that's going to be your 1 to 6 liter per minute flow rate. Okay. Good. All right. All righty. Good job, guys. Let's stop my screen share here. Okay. Let's take a quick little bathroom break. And then we can start on the PowerPoint. Does that sound good? So let's plan on being back in, let's just do 10 minutes. We'll take one of our breaks now. So 10:37, let's be back. Okay. All right. So your HESI review PowerPoint, this is under week 10 announcements. Okay, guys. So make sure you're looking at this. This will really help guide you. Also using your study guides from each week. For, that you utilize for quizzes and exams, that will help gear your studying as well. Okay. So I would be utilizing your PowerPoints and your study guides first off. If there's something on the study guide, you're like, oh no, I can't remember that, or something on the PowerPoint that you're like, oh no, I can't remember that, go back and read it in your book. Okay. Also the weekly HESI reviews that Professor Stiles has been doing, that is posted under one of the announcements as well. That will be really helpful. She did the recordings of each week PowerPoint from the HESI book in there. Okay. So that would be helpful to listen to all those reviews as well. Okay. And don't feel like, because our tests have been tough. But those of you guys who have been really successful with the test, don't feel like, oh, the HESI is going to be super duper easy. Okay. Because I've had some students do really, really well on all their quizzes and all their exams, and then maybe not focus on peds for their HESI piece, and then they wound up not passing the course. Okay, so make sure you guys are still focusing on peds, studying that material for HESI. Okay. I don't want to stress you out, but I also don't want you guys to go in there with the thought of it's going to be easy. Okay. Any questions? You guys all know your HESI schedule time and all of that. You should all know that. So next week we do not have class, okay? There's no in-person class. What I'll do for your attendance is be checking that you took your HESI. That will be your attendance for next week. The following week, right after class today, I'm going to make a little announcement in Course Cafe with sign-up times that we can meet during week 12. And it's just going to be like 5 minutes during, let's see, the Monday, what date is that? The 16th. Okay. So it'll be during our usual class time on Monday morning, but it'll just be a quick little check-in. Make sure you have your surveys done. And, you know, ask me any questions that you need, or we can talk about grades or what have you. Okay. And it'll just be you meeting with me, but it'll still be through the Zoom classroom. Okay. And that will be your attendance for week 12. If you guys do not come to that and you don't go to your week 1 of the next rotation courses online, you guys will automatically be dropped potentially because of lack of attendance. So make sure you come do that little check-in with me. Okay. Questions? No. Okay. All right, let's get started with the PowerPoint. So first, we're going to go over kind of some basic test taking strategies. So avoid using absolute. So if it says always, never, must, cure, that's probably not the answer. Okay. Don't read into the question, use only what's provided in the question. So don't sit there and like think, well, in some cases it's this, in some cases it's that, you know, just read the question. And I would say reread the question multiple times. Okay. Like I was saying during the Kahoots, if something's jumping right out at you, it's probably not the right answer. Okay. But take a second, reread the question and read all the answers before making your pick. You guys all will have plenty of time. You haven't struggled with having time at all this term on anything, okay? Or with not having enough time, I should say. Okay. Least invasive intervention first, okay? And then assessment is always going to be first, which is usually the least invasive thing that you can do, right? Is assess. Look at your patient, what's going on with them. Okay. And then your interventions are treatments come second, unless the child's in respiratory distress or some sort of distress, then you're going to be intervening some way. Okay. So you're going to skip the assessment point. But, also, before you do something to your patient, check your machine or your equipment and make sure that it's plugged in and that it's working accurately. I can't tell you how many times I was a nurse on the peds floor and we had to have, you know, their continuous pulse ox readings, and kids ripped off their pulse oxes. It was in bed with them. It wasn't doing right readings. The cords started not working or they got pulled from the machines. I mean, make sure you're checking your machine before you're doing an intervention to your patient. Okay. Now, obviously, if you look at your patient and they're cyanotic and blue, then you're going to intervene with that patient before you check your machine. Right. But you, for the most part, check your client before machines. Answers that delay care are usually the wrong answer. So make sure you're reading those questions and picking the one that does not delay care. Okay. 2 answer choices are opposite. One of those options is usually the answer. So if you're reading through your answers and you're like, Okay, there's only one word that's different in these two. I would focus in on those, reread your question, and then reread those two options and see which one makes the most sense. Okay. If the two answers are similar, then a lot of times neither is correct. So if two of the answers have hypertension, then usually you can eliminate those. Unless there's just something slightly, unless they're the opposites. So like hyper and hypotension. Okay. Is this confusing you guys, or is it making sense? It's doing okay. Okay. All right. If part of the answer is wrong, then it's all wrong. Okay. So if you're reading that answer and you're like, that's not the right thing, but then part of it seems right, it's still the wrong answer. Okay. And therapeutic communication, which looks at the client's feelings by asking open-ended questions. Okay. That's going to be one of the best things you guys can do as nurses. So as you're doing your test, if there's an option that's a therapeutic communication, like you're asking your patient an open-ended question to get factual information back, okay, from that patient directly, that's probably going to be one of the answers. You guys have questions on any of those test taking strategies? You can ask those now before we start in on the developmental milestone things. Basically, if just look at the question and the answers and really focus in on not jumping right to the first thing that's jumping out at you. Okay. Take your time, take a breath, reread it again. Okay. All right. Developmental milestones. So birth weight doubles at 6 months and it should triple by a year. So by 12 months, it should triple. Okay. Those are really key milestones to know about, is the weight piece of it. Birth length is going to double or increase by 50% at 12 months. Posterior fontanelles, so that back soft spot is going to close by 8 weeks. Okay. Social smile, that usually happens for the first time around 2 months. So that's when baby is interacting with parents or interacting with somebody and smiles. That's the social smile. Now you might see a random smile here and there before 2 months, but it's usually related to gas or a dream. Okay. Turning heads towards sound to figure out where that sound is coming from. That's going to start at 3 months of age. Okay. Your Moro reflex is going to go away about 4 months of age. So that's that startle reflex. Okay. Steady head control should be happening at 4 months. Turning over both directions. So back to belly and belly to back should happen between 5 and 6 months, but for sure by 5 months. Okay. Playing peekaboo, that should start after 6 months of age. Most 6-month-olds won't do that. It's probably closer to 7, 8-month-old thing. Okay. Good. Transferring objects from one hand to another hand, that's going to happen about 7 months of age. Stranger danger happens between 7 and 9 months of age, and then it also happens again between 15 and 18 months of age. And those are very normal developmental milestones. So parents might get a little nervous about why that's happening again between 15 and 18 months, but just reassure them that that's normal. Okay. Sitting unsupported should happen by 8 months of age. Crawling should happen by 10 months of age. Okay. Some kids do skip crawling and they go straight to walking, and that's okay. Fine pincer grasp, so that's your really fine, not using your whole hand to kind of sweep it to pinch it. That's going to happen between 10 and 12 months. Waving bye-bye is going to happen about 10 months. Walking with assistance, so parents holding their hand or walking along things, that's going to happen between 10 and 12 months. Simple words, mama, dada, cat, dog, those kind of very simple phrases should happen at 12 months, by 12 months. And they're going to be exploring their environment by crawling around and putting things in their mouth. Okay. So making sure that these parents have safety, baby safety kind of things in place. So outlet covers, not having a lot of cords out where babies can get to them, sharp corners, things like that. Separation anxiety. So here's a hint. The stages of separation anxiety consist of protest, despair, denial, and detachment. Know them and be aware of them because HESI likes to ask about those. Birth length should double by 4 years of age. Okay. We already said by 8 months, they should be sitting unsupported. They're half of their adult height at 2 years of age, which is crazy to think about. Throwing a ball overhanded, that happens by 18 months. 2 to 3 word sentences, that's 2 years. Use of scissors, that's 4 years. Tying their shoes by 5. It's really hard to find shoes that will fit 5-year-olds nowadays that have actual ties on them. So I feel like that's been kind of lacking in some kids, but you have to think about the situation that we're in, that most every shoe is Velcro now. Or little slip-ons like Hey Dudes or something. Okay. Which behavior indicates that thyroid hormone is working for a 4-month-old? Well, that they're meeting their developmental milestones of holding their head up, right? That would show you that thyroid hormone replacement is working. So being aware that growth spurts in adolescence begin earlier in girls before boys. Okay. So girls' growth spurts can start at age 10, even potentially. Same with menstrual cycles.
I got a question.
Uh-huh.
Back to when we were doing the Kahoot, and we had the question about how early girls can start to get I think it's the HPV vaccine.
The HPV, yeah. Uh-huh.
It starts as early as 9, right?
That's the earliest. Yeah.
If they're sexually active.
Yeah, or if they're at high risk for potentially having sexual activity. Yep. So like in my clinic, some of the kids that I see, I have a kiddo that unfortunately became pregnant at 12 years of age because she was sexually active and wouldn't tell any of us. Okay.
Okay.
Now, you don't always know who's high risk. You can't assume that people are high risk for sexual activity and just start, giving HPV vaccine willy-nilly starting at 9 or 10.
Mm-hmm.
But if
So
it's
Dr.
reported
Becker.
by the parent or something like that.
And the HPV, just to make sure I'm right, because I was watching the review too. So with the HPV, it only fights against the most prevalent strands, right? So you can be vaccinated and still end up getting HPV from a different strand, right? Okay,
yes.
Cool.
Yes. So it vaccinates against 9 strains of the most common cancer-causing forms of HPV. But
Okay.
yeah, there are other forms of HPV that you could potentially be exposed to that could also cause cancer, but there's a lot less likelihood of that.
Okay.
So Dr. Becker, for the 9-year-old, it's only if it's
high risk
in that situation, right?
Yes.
Okay.
Yes. Otherwise, they're going to start at age 11. But you can give it as early as 9. So like if you were to have a question that was, which I haven't seen any of these questions or heard any of these questions on the HESI or NCLEX, but if you were to have a question that was like, you have a 10-year-old female who's coming into your clinic that's, having sexual activity or high risk of having sexual activity, yes, you could give the HPV in that scenario. Hey, Tamika, can you change your name? It just says iPhone since you're using your phone. Can you change it to first and last name? Thank you. Okay. So girls are going to go through their growth spurts and go through puberty earlier than boys, always. Okay, unless they're in some delayed puberty. Temper tantrums are common in toddlerhood, but are considered normal behavior. So it's not abnormal for your toddler, your 2-year-old, your 3-year-old to be throwing fits and having temper tantrums. Okay, so reassuring parents that it's okay, even though it's kind of a pain when that happens. Okay. And adolescence is a time where the child's forming their own identity and rebelling against family values is common. Okay. School-age children are in Erikson stage of industry, which meaning they like to do things that they're asked and accomplish things. Peers are becoming more important at this age, but parents still have a lot more influence. So once again, you guys are going to have to go back to your Erikson stages and know those theorists. And there's no other polite way to say it other than you're going to have to just know them. Ages and just remember them. So if flashcards are your thing, I would be making flashcards for BAPPIes. Okay, so infants after 6 months, their cognitive development remembers pain. Okay. Fear, toddlers are really fearful of any sort of intrusive procedure. So think about, with getting shots or taking their blood, they're going to have a lot of fear about that. Preschoolers are fearing body mutilation. So they're afraid that, you're going to cut their arm off or their leg off or their penis off, things like that. Okay. School age fear of loss of control of their body. So they're going to fear that they, can't move their arm or their leg. Adolescents are going to fear any major change in their body image. So how something looks, how is that going to make my face look? How's that going to make my hair look? Is it going to make my hair fall out? They're going to be really focused on their body image. Accidents are a major cause of death in children and adolescents, okay? So you guys will need to develop teaching plans for parents that are developmentally appropriate and also accident/safety prevention techniques that are developmentally appropriate. Okay? So like medications across the board, there should be teaching about medication safety and not having adolescents have access to even everyday medications freely. Okay. Because in adolescence, the most common medication utilized is Tylenol for drug overdoses. Okay. So working with parents on teaching them that not having those things accessible to kiddos. Okay. Pain. So remember our pain scales. We have to kind of think way back. So cries is used for infants 32 weeks to 60 weeks gestational age. So this is typically used for preemies. Okay. PRS is used for a child's age 1 month to 36 months. Faces and PRS is in your book on figure 5.1, so in chapter 5. The poker chip scale can also be used for kids who are preschool age or older. So they can grab this many poker chips. This is how much pain I'm having. I don't see that one utilized very often, mostly just faces in preschool age kids. Okay. Preschool age is going to be 3 and up for faces. Okay. Numeric pain scale, use that in kids 9 and older for the book purposes and for HESI purposes. Now, you might have a very intelligent 7-year-old that you could use a numeric scale with in real life. But as far as testing purposes, it's numeric is going to be 9 and older. Alger pain scale, that's used from ages 3 to 12. It shows different levels of pain and discomfort, pictures of that. Documenting pain, you're going to obviously document what that child tells you. And then you also need to, if you do an intervention, so if you give that Tylenol, or you give them ibuprofen, or you give them, a narcotic pain med, you need to be redocumenting whether or not that was helpful. Even if they're doing something non-pharmacologic, you need to be reassessing if that's helped. So if they're doing heat, ice, distraction techniques, something like that, making sure you're keeping an eye on if that's truly helpful. Kids who are nonverbal, you can use the FLAC scale. You can also use the FLAC scale in infants, okay? So that looks at their facial expression, their leg movement, activity, cry, and if they're consolable, okay? Any questions about the pain scales? Ideally, we should try non-pharmacologic pain interventions first if they're telling you that their pain, is less than a 5. Okay. Making sure you're using age-appropriate and developmentally appropriate interventions for your non-pharmacologic things. Okay. So, offering a 5-year-old a pacifier probably isn't ideal, unless that pacifier is that child's comfort, I guess. Okay. So infants might enjoy being snuggled, held, rocked. Pacifier toddlers and preschoolers might, read to them or give them some sort of distraction through that, or let them watch a show or blow bubbles. Older kids, you might have them just play on their phone for a distraction technique. Before giving pain meds, okay, you need to make sure that that pain medication dose is safe, just like you should with any medication you're going to give that kiddo, but especially with pain medicines. So you need to make sure that that dose is appropriate for their weight, okay? Making sure you're doing their vitals before and after if there's any changes, okay? If kids are doing a PCA pump, so a patient-controlled analgesic pump, you can start that at age 5, okay? Prior to age 5, PCAs are not utilized because that child cannot truly report their pain and push the button and associate the two things before age 5. Okay. Kids may say that they don't have pain because they're concerned that they're going to have to get a shot for their pain. Okay. So making sure you tell that kiddo, nope, it's going to go through your IV. Do you have pain? Or no, you're going to have to swallow the pill. Do you have pain? So reassure them that it's not going to go through, a shot. Okay. Okay. Rubeola or measles. So these kids are going to have Koplik spots, which are black spots on the buccal mucosa. So on the oral mucosa, typically the cheeks. They're going to also have a rash that starts on the face and spreads downwards, so down to the trunk. And they're going to have photophobia. The vaccine that contains the measles, mumps, rubella vaccine, they get 2 doses, one that starts between 12 and 15 months, and one that's between ages 4 and 6. And then they're vaccinated for measles. Okay. Varicella zosters is the official name for chickenpox. Okay. Incubation period is 13 to 17 days after exposure. It is airborne. Okay. So extremely contagious. Measles as well is airborne. Lesions typically with chickenpox start on the trunk and then spread to the face and then to the proximal extremities. Okay. Starts as macular. So flat rash, flat red rash, becomes papular, so raised, and then vesicular. So then it's going to have that fluid-filled vesicle, and it looks almost like a teardrop, kind of. And then once those vesicles pop, those blisters pop and open up, then it's pustular. So then it's kind of got the scabby look to it. Okay. It's no longer infectious once the scabs have formed on all of those lesions. The other thing too about chickenpox is you will have some lesions that are macular, so some flat lesions, some raised lesions, some vesicular lesions, and some that have scabbed over, all on the same kiddo. Like you can have multiple different stages. Okay. So making sure that all of those scabs have formed is when they can return to their usual activities. Okay. We do the chickenpox or varicella vaccination at age 1, and then also 4 to 6 years of age. Okay. Rubella, which is German measles. So this is extremely serious if mothers of these children are pregnant. Okay. It can lead to loss of the pregnancy, even potentially. Okay. Hang on, I'm trying to look at a chat here. That's okay. Okay. So if kids with moms who are expecting or they have very young infants, parents should be told about rubella and the risks of that. It's one of those torch diseases. Remember hearing about the torch diseases during maternity, like toxoplasmosis and rubella, and that's why moms can't change kitty litter and things while pregnant. It's one of those torch diseases. Okay. So these kids will need to be isolated away from that parent who is pregnant and treated with something like Tylenol or non-aspirin containing agent because they're going to have a fever. They're going to need to report that to public health, prevent that child from scratching that skin. Same with varicella. Okay. So they might need to wear mittens. They might need like to soak in a baking soda bath or like an oatmeal bath that sometimes is soothing for itching. And they're also probably going to be on Benadryl, which is diphenhydramine. Okay. And hand washing, of course. Okay, nutrition. So iron deficiency is the most common nutritional deficiency across the board for kids, and it typically starts between ages 12 months and 3 years or 36 months. Also more common in adolescent females because of menstruation. Okay. So why is it most common in toddlerhood that iron deficiency happens?
Is that when we was talking about earlier how you moving the kids from either breast milk or to regular milk?
Yep, so that happens at 12 months, right? So specifically iron deficiency anemia, that's going to start at 12 months. What we were talking about earlier was just anemia in general, starting naturally, physiologically between 3 to 6 months of age for infants. That just is something that happens because they're no longer getting mom's blood cells. They're starting to make their own. But this is iron deficiency anemia. So this is when they have low iron, which happens most commonly with having too much dairy milk. okay? But also toddlers aren't eating a lot of green leafy veggies, which also are high in iron, okay? So toddlers kind of have the double whammy of the milk and iron, or poor diet choices. Most common vitamins that kids are deficient in, especially preschool and school age kids, are A, C, B6, and B12. Okay. And then think about adolescents. They're going through a lot of growth. They're going through puberty. A lot of them are active in sports or other activities. So they're going to have an increased calorie need. And also they're going to need increased protein, zinc, iron, and calcium because of their growth period that they're going through. 24-hour recall is a good way for you to assess whether or not kids, specifically adolescents, may have an eating disorder. And you could have them recount, water, drinks, and foods that they're eating in that 24-hour period. You can also, if you're really concerned about an eating disorder, have those kids be keeping a food journal, or the parents keeping a food journal for multiple days, and then have them come back in. Also asking parents how much fruits or veggie servings they're having a day or in a week, and meat and bread and all of that, making sure that they're getting all of those food groups and appropriate amounts of all of those food groups. Okay. Diarrhea. So with diarrhea, you're going to be metabolic acidosis, right? Because your diarrhea is alkaline and you're having a lot of it. So you're getting rid of the alkaline, the base, and you're left with the acid. Okay. Eventually dehydration leads to shock and then also death potentially. Signs of shock in kids with diarrhea are going to be decreased blood pressure, rapid, weak pulse, gray colored skin, or any other kind of skin color change, and changes in mental status will be your biggest sign of shock. Okay. And this would be what type of shock?
Hypovolemic.
Right. Good. Your signs of dehydration, of course, that's skin turgor. Good luck doing that routinely on kids, but it's the sign, okay? Dry mucous membranes, loss of tears, weight loss, depressed fontanelles if their fontanelles are still opened, but of course, decreased urinary output and increased specific gravity on those UAs. Those are all going to be good signs of dehydration. IV fluids with potassium should not be given until those kids have adequate urine output, which would be 1 to 2 mils per kilogram per hour. Okay. But potassium eventually will be added on almost all pediatric patients to their fluids. But don't do that until they're having your appropriate urine output. Okay. Nursing plans and intervention for kids with diarrhea, obviously INO, making sure you're keeping them hydrated. Do not be taking their temperatures rectally if it's an infant, even though that's the best route in infancy. Do not be doing that. You may need to check the stools for pH or glucose or blood, keeping an eye on that urine spec graph. And then also they may need to be placed in isolation and hand washing. Hand washing with soap and water for diarrhea kids. Okay, because your C. diff, the transmission can still occur if you're using hand sanitizer. Okay, indicators of child abuse. So obviously if the injuries are not lining up with what the parents are telling you, or the parent's story changes, or that childcare provider's story is changing, Those are all red flags. The child is, telling you something different from the parents. That's another red flag. If the injury itself do not go along with what the parents are saying, or the care provider or the potential abuse perpetrator is saying. Okay. Also, you should be concerned of if there's a delay in medical care. Okay. That's kind of a concerning thing. Or bruises in unusual places, or bruises that are in various stages of healing. So one brand new bruise, one bruise that looks really old. Same with fractures, like you get an x-ray and there's old fractures on there, or new fractures, old fractures in various stages of healing. That's concerning. Burns, like with an iron or cigarette. Immersion burns, so like if it's a symmetric shape burn and that kiddo sat in the bathtub, that, or was forced to go into the bathtub, or was forced to put their hand in hot water, that could be a sign potentially. Shaking baby syndrome signs, so babies who have retinal bleeds from being shaken, things like that. Okay. Failure to thrive, not coming to their appointments. Those are also concerns for child abuse. Okay. And remember, you are legally required as an LPN to report suspected child abuse. Okay. And that reporting looks a little different based on, each state. Poisoning. This is one of the most common potential risks of injury and death in kids. This could be ingesting, inhaling, or absorbing the toxin substance. Ipecac is no longer recommended, so that's what kids used to be given to like make them throw up. Okay, so teach parents not to induce vomiting. Okay, that they're being tubed and given Ipecac. Okay. Respiratory disorders, common signs of respiratory distress in children. Restlessness, they can't get comfortable, they're fidgety, they're all over the place, and they've had a cough and congestion and all of that for a period of time. Increased respiratory rate, they're going to have diaphoresis, increased respiratory or pulse rate, retractions, grunting, nasal flaring, absent breath sounds or abnormal breath sounds, or advantageous breath sounds is another term for that. Okay, head bobbing, tracheal tugging, any use of accessory muscles, and then of course decreased PO2 on blood gas and increased PCO2. So decreased oxygen, increased carbon dioxide on blood gas. We'll also show you that. Those are going to be later signs though. Okay. Interventions for asthma, obviously making sure that they're taking their bronchodilators as prescribed routinely, or their corticosteroids inhaled as prescribed routinely, managing their hydration status, monitoring their blood gases for respiratory acidosis if they've been in an asthma exacerbation. Okay. Going to be giving these kids oxygen or neb therapies as needed. Usually you want the pulse ox to be higher than, so 95% or higher. Okay. These kids might hang out at 95% when they're not sick, so their oxygen saturations can be lower for sure. Okay. Cystic fibrosis, lung insufficiency is the most crucial problem, the biggest issue, but pancreatic insufficiency, loss of sodium and chloride through the sweat, biliary obstruction, so there's going to be obstructions in their bile ducts, and then dysfunction of their reproductive system. So it's a multi-system disease, even though when you hear cystic fibrosis, you think of respiratory effects, right? But it's affecting multiple body systems. Okay. Kids with cystic fibrosis are going to get 1.5 times or 150% of the usual daily caloric input to maintain their normal growth and development. Okay. Kids with CF are frequently admitted with failure to thrive and things like that because they're not able to get enough calories and maintain their fats and things that they need. Okay. We'll talk about this one and then we'll be, I'll take your questions. So these kids with cystic fibrosis are going to need fat soluble vitamins. So A, D, E, and K. Okay. And they're going to have to take those in water soluble form because they cannot absorb fat soluble vitamins. Okay. They're going to need their pancreolase or their pancreatic enzymes with their foods. Okay. So that way they can absorb all the nutrition from that food. They'll be on oxygen or neb treatments as well. They'll also get chest physiotherapy or chest CPT is another term for it. So those vests that they put on, and there's a machine that kind of shakes their chest. They'll be getting those therapies multiple times a day. And then also, they may also need, like infants, they make little cups that parents can kind of pat on their back with that for chest PT and infants. Also, high calorie, high protein, high fat. Okay. Low to moderate carbs. Okay. The reason why we do low to moderate carbs with these kids is because otherwise, if you're increase carb intake, you're going to have increased CO2. Okay, so that's going to deplete their respiratory drive. Okay, also making sure that kids with cystic fibrosis, even though they have cystic fibrosis, they're doing age appropriate normal activities as much as they can. So if they want to play soccer, totally let them do it. Okay. All right. We're going to stop there. Any questions, comments, concerns at all?